Let's hear the case.
Okay, so this is a 85-year-old female, the chief complaint of shortness of breath.
85-year-old female complained of shortness of breath. Okay.
Last 4 days.
Shortness of breath times 4 days. All right, tell me a little bit more about the shortness of breath.
Okay, so the patient has been having shortness of breath since 4 days,
Okay.
with increased difficulty with ambulation
Mm-hmm.
and
So there is increased shortness of breath with ambulation.
Yes.
There's maybe an exertional component, right?
yes.
Okay. Exertional, we can say that. What else?
So she has been having a lot of dry heaving with belching with the vomiters that is brownish in color.
Heaving, belching.
Yes.
Okay, what else?
So the patient has chills but denies fever.
Chills. Okay. All right.
The cough is in the morning where
So the patient is also having cough.
yes,
Okay. And is it productive or non-productive?
non-productive cough.
Okay. Non-productive cough. Okay. No fever?
No fever, only chills.
Okay. So when you talk about, let's talk about the differential diagnosis of shortness of breath. Okay. What are the three major categories of shortness of breath we need to worry about? What are the things?
You mentioned shortness, okay.
Three
Cardiac.
systems. So let's say cardiac. Okay. What are the causes of cardiac? What kind of things under cardiac?
CHF.
Huh?
CHF.
CHF, definitely. Okay. So what kind of questions, when you're thinking about CHF, what kind of questions you should be asking the patient to differentiate it's not CHF?
Past medical history.
Very good. Any history of CHF in the past? But which one? When you talk about the symptoms and the signs, we need to think about likelihood ratio. Okay. So whichever symptoms give you the highest likelihood ratio, how do you there's something called a positive likelihood ratio and negative likelihood ratio. So if the positive likelihood ratio is high, that means your odds of having the disease is like extremely high. Okay, so it would be a good idea kind of which one. So if somebody with a CHF coming in, so which symptoms will give you the highest positive likelihood ratio? Which symptom is that?
Orthopnea.
Nope.
Paroxysmal nocturnal.
Paroxysmal nocturnal dyspnea. Okay, this give you likelihood ratio around like a 3 to 4. So one question you always have to ask the patient is about paroxysmal nocturnal dyspnea. Okay, and how do you ask for that?
Does he wake up at night coughing with a shortness of breath?
Okay, and how long? Like when you, is it 1 hour, 2 hour?
It stays for more than an hour.
Yeah, usually like 1 to 2 hours.
It
You're
stays
lying
for-
down, pulling out all the blood to the heart.
Yeah.
So what does that mean? The PND, is a likelihood ratio 3 to 4. That means the odds can go up to like at least 15 to 20% high. When somebody have PND, then you have to think about definitely there's a CHF definitely has a component to it. Okay, and then the next one with the leg swelling, have they give you the likelihood ratio around like 1 to 2. So you can also say like 10% more. So you have to ask that to roll out. What are the other cardiac causes? Shortness of breath.
Acute MI.
MI. Okay, so always when somebody with a shortness of breath, there was a study done, they took like 100 patients come with a shortness of breath, 30 to 35% already have some kind of cardiac component on the shortness of breath. So always kind of think when you have like anginal equivalent, that's what they call, right? Anybody know the term? Remember the term? Anginal equivalent shortness of breath. So cardiac component. So MI, so you still need to roll out, right? What are the other causes?
Any worsening of the valvular lesion? Sudden
Any kind of
worsening
valvular lesion, yeah, like that
Some
kind of contribute to like a
worsening of
CHF, valvular lesion, and all that is important. Okay, so we talk about cardiac. Next one is the pulmonary. What are the things in the pulmonary you have to worry about?
asthma exhibition.
Asthma, right? We got
Pneumonia.
COPD, we got pneumonia. We can talk about what else?
ARDS.
Yeah,
Pulmonary embolism.
pulmonary embolism is a very important thing. So, because, okay, we now talk about pulmonary embolism. What else? Anything else we missed?
Pneumothorax.
Pneumothorax, yes. Very good. All right. Okay, what else? So we talk about cardiac general, we talk about pulmonary cause. What is the other major
CNS.
group or like system is involved with the shortness of breath?
Can be CNS.
CNS,
Hematological.
huh?
Hematological.
Hematological, okay. So could be like anemia, right? So we always, especially if somebody like female in the menstruating, they're losing a lot of blood, they could have shortness of breath. If somebody with previous history of malignancy and all those, we have to think about that causes. Now all of this, when a patient comes in with a shortness of breath, I always, before when I go to the ER, when you see the patients first, you need to think about like what is the emergency. Okay, what emergencies I should act on it like right away. Otherwise, what are the people going to do? They're going to do an H&P, take their 2 hours doing the H&P, then come up with the diagnosis, and patient may be dead by that time. So what are the emergencies in this situation? Could kill the patient right away if you don't act on it. What's the number one emergency if somebody come with a shortness of breath?
Consciousness levels of.
Give me a disease, like disease process. I'm not talking
pulmonary edema.
They don't kill the patient like right away. What could kill? Pulmonary embolism, right? Patient could be dead right away. So if you're suspecting pulmonary embolism, what kind of questions you need to ask the patient?
Is the patient in any
Association with chest pain.
Yeah, associated with chest pain.
Any,
What else?
Any past
Any
history of
reason?
venous or arterial clots.
Okay, what else?
Any travel history.
Travel history. Always make sure, patient have taken travel like, 4 to 8 hours or like an air travel, those kind of thing. Previous history of pulmonary embolism or coagulation disorders and all those kind of things. So pulmonary embolism definitely. What else? MI, right? That could kill the patient right away, especially which MI would kill the patient?
The
STEMI or non-STEMI? STEMI,
STEMI.
right? Non-STEMI kind of give you a little bit of time. STEMI, that's why you have to rush the patient. You got the 90-minute window-to-door time and all those kind of things. So always kind of think about what else? Pneumothorax, can they kill? Usually like tension pneumothorax,
Tension
right?
pneumothorax,
Usually the
yeah.
presentation is what? Very painful. You will know patient is having tension pneumothorax, okay? So what are the other complaints this patient have? So only thing at this point we know there's a patient with a shortness of breath. We did not we don't know, you didn't tell me anything about any of the CHF symptoms or any of the cardiac, doesn't suspect anything about the pulmonary embolism. Only thing we know, there's shortness of breath associated with chills and cough. Why is it chills is important?
It's a sign of infection.
Infection, probably you need to think about maybe like bacteremic or those kind of things also important. Okay? Any other complaint the patient has?
She denies
Any other complaint? Okay. So tell about the past medical history. What is the past medical history?
She is positive for AFib,
AFib.
anxiety,
Okay.
asthma,
Uh-huh.
cataract, COPD,
Asthma, COPD. Okay.
diabetes, GERD,
Diabetes. Okay.
GERD.
Okay. So now we know, this patient asthma is a pulmonary component already. We need to worry about like a COPD or any of those kind of symptoms. Okay. What else?
Cancer,
Cancer. What we need to know, like what type of cancer, right?
yes.
What type of cancer does he have?
Lung cancer,
Lung cancer. What do we know about the lung cancer? Do we know the stage? It's like metastasis and all of these things we need to know when you present it, right?
she didn't mention any.
Okay, that's okay. Let's move on. So, only thing we know, this patient have diabetes. What does diabetes? It's usually like an immunocompromised. They might not have the usual symptoms of like an infection kind of going. We need to know COPD and asthma. There is like,
And sleep
which
apnea.
one have usually more chances of asthma or COPD? You have like pneumonia.
COPD.
COPD. Asthma patient like usually never have a pneumonia picture. Okay, remember that. All right. So we did the past medical history. What is the next thing?
History of sleep apnea as well.
Sleep
She was in
apnea,
CPAP, but
okay.
She discontinued it and she's not interested in.
Okay, so you would like, that can also cause like shortness of breath is, and the past medical history you talk about like, and next thing is like allergies. The patient have any allergies?
Yes.
What are the
She-
allergies?
She's allergic to Bactrim.
Bactrim?
Yes.
Okay,
And adhesive tape.
all right, Bactrim allergy, what else? And then we have no family history, right?
So the family history is positive for high cholesterol, high blood pressure,
Okay,
and heart disease as well.
heart disease.
Yes.
So we need to, because of the heart disease, then another component we need to worry.
And
Now let's talk about the medication. What medicine the patient is on?
okay, the home medication she's
Yeah.
taking right now.
Just give me the names faster.
Levocetirizine, prednisolone.
Yeah.
Pramil
Why is
is-
the patient taking prednisone? That's the question. You know, this patient, that kind of tell me, maybe he had like a long COPD kind of, maybe it's been going on for a long time. Maybe the patient is on prednisone. What else?
Okay, rabiprazole, rosuvastatin.
Mm-hmm.
All the
Rovastatin, right? So the kind of like, why is it rovastatin is important? Like, why is it the, let's talk about rovastatin a little bit. What is the main complication of rovastatin can cause?
Myositis and rhabdomyolysis.
What else?
Raised liver
Rovastatin.
enzymes.
What is the relation with the statin and diabetes?
New onset diabetes.
Yeah,
Odds,
like is
yeah.
the odds ratio is almost like a 1.67. Okay, so the rovastatin can cause like new onset of diabetes. What else? The rovastatin is like, you know, when you talk about the statin, just kind of remember, like, you know, I'm not kind of related to this case. You have to think about the hydrophilic and the lipophilic. Okay, so try to stay away from lipophilic. That's where like can cause a lot of complication. Rovastatin is a hydrophilic statin. Remember that. Okay.
The patient is in allopurinol hazard because she's a history of gout.
Gout, allopurinol, okay. That doesn't, I don't think it's going to affect any
Right.
of that. What else?
Rivaroxaban, montelukast.
Okay. Asthma, probably. What else?
Promethazine codeine combination.
Okay.
And she's on. That's it.
All right. Social history, do we know? Smoker?
No, she's not a smoker.
Okay.
Currently not smoking. She's not on any drugs. And
Okay.
she is not sexually active.
All right.
Yeah.
So tell me the vital signs. So why is it like, I mean, you know, what vital signs, why is it important? Let's talk about the vital signs on the presentation.
Okay, a few more drugs which she's on is like amprezolam.
Mm-hmm.
She's on spironolactone,
Uh-huh.
fluoxetine.
Why she's taking spironolactone? Which, I mean, when do we use spironolactone? And what does it cause?
Potassium spin but a gynecomastia.
I mean, it can cause the gynecomastia, like painful gynecomastia, but probably like CHF, right? CHF stage 3 or 4 had like some benefit in the remodeling. So maybe I'm kind of wonder because of this patient, you didn't tell me anything about like CHF history or like sometimes ascites. I don't know why is he taking. But tell me the vital signs since we're just kind of running out of time
Right. Okay,
on
the vital
presentation.
signs.
Yeah,
Her blood pressure is normal, 122/78.
Mhm.
Her pulse is 92.
Yeah.
Respiration is 18.
yeah.
Saturation level is 90%.
90% saturation. So only thing we know the patient is hypoxic, right? So pulmonary component, most likely kind of things too. There could be still like what? Pulmonary embolism, still we need to kind of roll out and all those
She's
kind of things.
afebrile.
She's afebrile, right? I mean, if the temperature is like greater than 100, the likelihood ratio of pneumonia is kind of like really high, okay? If the respiratory rate greater than 30, then also the likelihood ratio for pneumonia goes like 7 to 8. That means my odds of diagnosing pneumonia kind of like 30 to 40% higher. Okay. All right. So what examination would you do? What are the things you're looking for when you look at the patient? What do you think? Let's look at it. What do you have to do?
Physical examination.
Physical examination, like what is the first thing? You have to look at the patient cachectic, right? This is the patient have like lung cancer
Yes.
and those kind of thing, maybe kind of thing. That's what kind of you look at the respiration, right? If there's like a diagonal respiration or like is there a distress? They're using the accessory muscles or anything kind of support our any of this. What else we need to look?
Any color change, cyanosis.
Cyanosis is very important. Hypoxic, very good.
Dehydration around
All
the
right.
mucous membranes.
Okay, dehydration, but not like, why would you worry about somebody with shortness of breath? Not, I mean, of course you should worry about, not that much, right? What else? Like, I mean, anemia, I mean, you can,
Anemia, yeah.
anemia, you look at it, right? If there like anemia can causing shortness of breath, should be, what else?
Any swellings around the neck.
Yeah, swelling of the
lymph
neck,
nodes and
like
all
what
that
are we
stuff.
looking for the neck?
Any mets happening.
Any, like, I mean, you know, any lymph
Any
node is
tracheal
important, right?
elevation.
If you talk about lymph node, what is the lung cancer? Which lymph node we have to worry about?
Left-sided, left supraclavicular.
Left supraclavicular or right supraclavicular?
Right.
No, right.
Right
Left is for
supraclavicular.
stomach, left.
Okay, stomach is in the virtue like on the left side,
Yeah.
so you have to be careful. So we just, I mean, you have to think which system you're going to examine first, okay? You have to look at the JVD, don't we?
Yeah.
Like any CHF.
Yes.
We have like JVD greater than like, 8 centimeter, then the likelihood ratio is like extremely high. And then listen to the lungs, what are the things kind of support like highest likelihood ratio for CHF? What is that?
The presence of basal crackles.
S3, okay? If
S3.
somebody writing a question like 45-year-old or 50-year-old come with the shortness of breath, S3 found CHF. There's no question, nothing else, okay? If it is COPD, what are they going to have? Like decreased breath sound, that has the highest likelihood ratio. If it is pneumonia, egophony give you like, I think, the pneumonia, the highest likelihood ratio is asymmetrical chest expansion, okay? You put this behind the, put the hand, and the chest expansion is like asymmetrical, likelihood ratio is like 44. That means the lung pathology for pneumonia is extremely high. It could be up to, like I think 44 or something, like 80-90% higher chance of this. All of this things you have to lung exam, crackosound, all of that important. But think about likelihood ratio. Since we're running out of time, I'm just going to go a little bit faster. Okay. So we did that. Like any positive finding on the exam?
So like she's having coarse breath sounds.
Okay, coarse breath sounds.
Yes.
That's all we have.
Yeah,
Okay. So now we just kind of did the examination. What labs we need to do? We just what labs we need to do? Let's start with the CBC, right? What is the most common? What are we looking for CBC? One, we have WBC, right? We need to know leukocytosis or leukopenia, right? We need to know what are the criteria for SIRS. Who's going to tell me the criteria for SIRS? Heart rate greater than 90, respiratory rate greater than 20, and WBC greater than 12. And WBC less than 4, like leukopenia and all that too. PCO2 can be used in some criteria for that. So we just have to rule out sepsis. Again, leukocytosis. We also, hemoglobin is important. It's anemic in COPD patient. What is hemoglobin? What are they going to have?
It's going to be a polycythemia.
Polycythemia. So if it's like somebody with polycythemia, and I'm thinking either dehydrated or they are like COPD kind of picture, right? And then what else? So we did the CBC platelets. I don't think it's much important in this case. Maybe reactive could go high. So let's look at the BMP. What are the things? Sodium is important.
Sodium is
Why is that?
We'll have a.
Which pneumonia is associated with the sodium low?
Legionella.
Legionella. Okay. So
Legionella.
kind of sodium is kind of thing like this GI symptoms. This patient have like a little bit of GI symptoms, right? They're belching and all that. So I had to consider like a Legionella antigen on this patient. I would definitely check for it. Okay. What else? So we just did with the bicarbonate is important.
Bicarbonate is important.
Because you can have
And
metabolic acidosis, lactic acidosis, like septic picture, right? You have anion-gap metabolic acidosis and all that too. Renal failure, I don't know. Maybe like if there's CHF, that can have negative impact on this. Blood sugar is important. This patient have diabetes, right?
Yes.
We need to know. What else we should check?
Bandemia,
we need to procalcitonin level is very good. So cheap test they should procalcitonin, ESR, CRP, or those kind of things, but definitely procalcitonin. What else?
Chest X-ray.
Okay, chest X-ray is important, definitely. We already think, blood culture we have to do.
Chills.
Okay, let's talk about the labs. Mainly anything else. Do we need to check troponin?
Yes.
Okay, what else? What else we need to check to differentiate between cardiac and the pulmonary disease? What is the lab test? BNP, okay.
Yeah.
BNP is very important. Which condition you have to be give you a false elevation of BNP if the patient is like obesity, okay? Be careful about this. And so we have to check all this, even then we have to do an EKG because we said, there may be cardiac component, anginal equivalent, we have to worry about it. So all this need to be done. So what did the chest X-ray show?
Chest X-ray.
Should we also do D-dimer?
We'll come back to that. Okay, when do we do D-dimer? That's also is important. Okay.
So the impression of the chest X-ray shows patchy A-space consolidation.
Okay, so we have a chest X-ray patchy consolidation kind of supported. What is the lab value WBC count again?
13.3.
WBC count is 13.3.
Hemoglobin 11.
Okay, and then chest X-ray patchy airspace disease. Do we check lactic acid? Is it important to check lactic acid? Nobody said that. We need to check lactic acid. Okay. So what's our diagnosis in this patient?
Infective pneumonia.
Yep, we got pneumonia, right? But probably it was not admitted anywhere. The best term, always use the right term when you're community acquired pneumonia. What's the next thing you do when you say suspect? What is the next thing when you have a diagnosis? What's the next thing you do? Next, always do risk stratification. Okay, do curve 65 or pneumonia severity index. You need to know in and out that. Why is it important, curve 65 and pneumonia severity index?
To decide whether the patient needs to be treated
inpatient or outpatient. So they're going to ask for the board, so you have to know in and out curve 65 and pneumonia severity index you calculate. How do you treat it? You can just I mean, atypical organism we have to cover, and then IV subtraxone, azithromycin, probably like a good choice at this point. The patient does not appear to be septic, right? And then we have to roll out the other causes. We have to troponin, which to make sure there's no cardiac, BNP, or those kind of things. We need to roll out the BNP, right? And then also, like pulmonary embolism is very high on the list. How do we approach that?
We'll be doing fibrinogen.
Nope,
and,
we'll do a
the
Wells
other-
criteria.
Wells criteria.
Okay, I mean risk stratification before. That's why value-based care is very important. So in this case, what I would do is I calculate the Wells score. If it is low, I don't do anything. Stop it.
Right.
If it is high, I might do like a D-dimer first, and then go to like a CT and all that too. But in this case, we have a different diagnosis already. There is like shortness of breath. There is cough. There is leukocytosis. There's patchy infiltrate. So you just kind of treat it always. Okay, that's it for today. Thank you.